the second lecture in the liver. Objectives of this lecture is to speak about liver cysts, hydatid cyst, amoebic liver cyst, pyogenic liver cyst, simple liver cyst, polycystic liver cyst, miscellaneous like tuberculous liver cyst and cystic tumor. Let us speak first about pyogenic liver abscess. As you could see its picture in this slide, this is CT scan showing pyogenic liver abscess of the liver. It is either single, which is large, or multiple and small. It's either acute or chronic. Manifestations of pyogenic liver abscess include fever, lethargy, and malaise, sometimes associated with right upper quadrant of abdomen discomfort rather than pain, and includes anorexia and unwell looking. Patient at risk to develop pyogenic liver abscess: 1 sickler, 2 elderly, 3 malnourished, 4 immune suppressed, 5 diabetics, and lastly post-traumatic and post-operative patients. Microorganisms include most commonly E. coli, Streptococcus milleri, and less likely Streptococcus faecalis, Klebsiella, Proteus, and Staphylococci. Sources of abscess of liver could be via 1 bile duct, and this is called ascending, and it is commonest. Number 2, portal vein. 3, perihepatic infective focus. 4, hematogenous, example hepatic artery. Diagnosis of pyogenic liver abscess: 1 ultrasound and CT scan to see multiloculated cystic mass lesion. Sometimes X-ray might be beneficial to detect air fluid level. Treatment: 1 antibiotics, example aminoglycosides or cephalosporin, plus drainage under ultrasound guide, which is called ultrasound guided aspiration, or laparotomy for drainage. It might be beneficial. Amoebic liver abscess, which is called tropical abscess or dysenteric abscess. 70% of them solitary large abscess, and 30% multiple small abscesses. Microorganism is Entamoeba histolytica, which is parasite, leading to dysentery, goes to the liver, leading to localized liquefaction, resulting in abscess. Causes or outcome of the disease: 1 amoebic hepatitis, 2 amoebic abscess, which contains chocolate pus called anchovy paste, or the lesion become encapsulated, dormant lesion, or the lesion burst to the lung and pleural cavity, peritoneal cavity, hollow organs or skin. Clinical feature: anemia, weight loss, pyrexia, night sweating, pain in liver area, and enlarged tender liver. This slide shows CT scan of amoebic liver abscess. Thick wall, homogeneous content. Diagnosis of amoebic liver abscess: ultrasound and CT scan, sometimes chest X-ray beneficial. Isolation of organism from the stool is beneficial to detect Entamoeba histolytica, and questionable from liver lesion, because difficult from abscess, because it is in the periphery, not in the content, not in the chocolate pus. Treatment: 1 metronidazole 750 mg TDS for 7 to 10 days, this is main line of treatment. 2. Possibly beneficial aspiration under ultrasound guide. 3. Laparoscopic or open drainage might be needed. Indication for drainage: 1. No response to metronidazole after 5 days. 2. Too big size. 3. Bacterial superadded infection. In this slide, we are going to speak about few words about simple liver cyst, which is coincidental finding. It is regular, thin wall, unilocular, homogeneous, no surrounding tissue response, and no variation in density within the cyst cavity. CT scan shows sharply defined margin, has no measurable wall, no septation, calcification, or enhancement mural nodules, as you could see easily in CT scan that in this slide. Treatment: no treatment if it is asymptomatic. 2. Aspiration under ultrasound guide, which is possibly there is a possibility of recurrence by using this technique. And 3. Definite treatment for large symptomatic by using open or laparoscopic deroofing. In this slide, we are going to speak about polycystic liver disease, which is congenital, including multiple liver cysts associated with polycystic formations of cysts in kidneys. It is often asymptomatic and coincidental finding. It leads to discomfort in right hypochondrial region, sometimes severe pain due to hemorrhage into a cyst. Ultrasound or CT scan used in diagnosis of this disease. Treatment: analgesia. If no response, then open or laparoscopic fenestration of the liver cyst. We are going to speak about the most important type of cyst in the liver, which is hydatid liver disease. Worm and life cycle. It is common in Mediterranean countries, caused by larvae of Echinococcus granulosus. Intestine of the dog is definitive host, leading to eggs. Eggs goes to the grass, and then this goes to the sheep or human, goes to the portal blood. 70% goes to the liver, 20% to the lung, 10% elsewhere in the body. Pathology: it consists of 3 layers. 1. Adventitia. 2. Ectocyst, laminated membrane. 3. Endocyst, germinal membrane. Now this cyst contains fluid, hydatid cyst fluid, and it has characteristic features. 1. Crystal clear. 2. Specific gravity 1.005 to 1.009. Under tension, active cysts contain large number of small daughter cysts, and lastly contains no albumin. This slide shows 2 pictures of ultrasound scan showing hydatid cyst of the liver. This slide shows a CT scan of big liver hydatid cyst, and you could see the operation for it. Exposure of the liver area contains the cyst, and then these are the multiple daughter cyst and laminated membrane in the kidney dish during surgery. Clinical features of hydatid cyst: 1. Symptomless. 2. Abdominal mass. 3. Pressure manifestation includes discomfort, fullness and dyspepsia, and jaundice. Number 4. Complications: A. Suppuration. B. Rupture. And here the rupture could be intrahepatic biliary rupture. Daughter cyst goes intrabiliary, leading to jaundice and acute cholangitis, or rupture to the peritoneal cavity, and then the patient at that time present as an acute abdomen after minor abdominal trauma, or rupture to the pleural cavity, and then the patient could present with dyspnea and symptom of respiratory system. Course of the disease: 1. Dead calcified cyst. 2. Enlarge gradually, become manifested by its size, and may float in the peritoneal cavity, and then the differential diagnosis there would be mesenteric, pancreatic, or renal cyst. Number 3 of the course of the disease: complication, example, rupture of hydatid cyst or infection. Diagnosis of hydatid cyst in the liver: 1. Ultrasound scan showing multiloculated cyst. 2. CT scan and MRI showing floating membrane within the cyst. 3. Serological and immunological tests: A. Antibodies to hydatid antigen by ELISA. B. Cazzoni's test 75% positive. C. Complement fixation test. Treatment of hydatid cyst: A. Surgical treatment by either open surgical treatment, A. De-roofing with evacuation of content, B. Excision of the cyst, C. Less likely liver resection, or 2. Laparoscopic surgery, which might be beneficial. Scolicidal agent used during surgery: 1. Ethanol alcohol 95%. 2. Hypertonic saline. 3. Silver nitrate or 0.5%. 3. Povidone iodine. Medical treatment: mebendazole 40 to 50 mg per kg, albendazole 10 to 15 mg per kg, praziquantel 40 mg per kg. We get used albendazole 10 to 15 mg per kg after surgery to prevent the recurrence of hydatid cyst. Complication of surgical treatment of hydatid cyst: 1. Biliary leak leading to what we called it biliary fistula. 2. Suppuration, and this would be either subhepatic, subphrenic, or intrahepatic abscess. 3. Liver tissue damage and bleeding. 4. Recurrence. 5. Missed small deep cyst. 6. Injuries of adjacent organs. 7. Cholangitis. 8. Anaphylactic shock. 9. Contamination of peritoneal cavity, and this would be avoided by careful steps during surgery and using albendazole, as I've already mentioned that previously in the last slide. And lastly, in the complication of surgical treatment of hydatid cyst would be wound infection. This slide we are going to speak few words about tuberculous liver abscess, which is cyst as well. It is a rare one caused by Mycobacterium tuberculosis. It happened mostly in endemic area. It might associated with pulmonary TB or tuberculous lymphadenitis, but it might not. Tuberculous liver abscess presented with non-specific symptoms or after diagnosis of pulmonary TB or other extrapulmonary TB. Diagnosis by ultrasound and CT scan, treatment, drainage plus anti-TB course. At the end of the second lecture of the liver, could you please have a look for these few important questions for training? Thanks.